It's a left dominant system with the collaterals filling almost the RCA completely. The RCA could not be engaged selectively. The patient was thus shifted to the CCU, and coronary artery bypass grafting was advised. He was seen by 2 surgeons and counseled repeatedly, but the family and the patient himself refused to undergo CABG. Thus, it was decided to proceed with PCI. Using the right femoral root, an upfront IABP was placed, and then the 7 French guide was taken through the radial axis. A scion wire was placed in the left circumflex and a whisper wire into the LAD. The lesion was pre-dilated with the 1.5 and a 2.0 balloons. But a 2.5 balloon could not cross the lesion. So thus, rota with a 1.5 burr was done from the left main to the LAD. The lesion was further prepared with a 2.5 and a 3.5 non-compliant balloons. The diagonal was wired, and then a 3.5 22 DES was placed in proximal to mid-LAD, which was then overlapped with the 4.0 22 DES from the ostial left main to the LAD and with guideline support, giving this result. The far right picture here shows that there's plaque shift into the ostial circ as well. The circ was, pot was done with the 5.0 balloon, and then the circ was rewired, and so was the diagonal. The POVA to the diagonal was done with the 2.015 balloon, and the struts of the circ were open against the left circumflex. A report was done to correct for any deformities with the 5.0 balloon. The IVUS run was done in the end, which showed good stent expansion with no malapposition or dissection. Unfortunately, due to some format issue, I could not upload the IVUS images. And this was the final result. Left me, this is a paper from a center in France who've done over 40 patients in octogenarians, although my patient is just a few years younger than 80, but still doing, they've shown it to be safe and with good outcomes. And the learning point, if you consider this state-of-the-art review published in the JACC, that balloon uncrossable lesions, you ultimately have to go to rotablation to prepare the lesion, and then further prepare the lesion if need be. Thank you.
Invite the panelist to ask
LV
questions.
function? What was the LV function?
So the LV function was normal. It was 55% reported with no segmental wall motion abnormalities.
Then, what's the rationale for putting IBP before procedure?
It was a left dominant system. There was some mild disease at the left circumflex ostium as well, and the whole left system would be in jeopardy. The left main is severely diseased and calcified, and so was the LAD. So for support in case the patient crashes, IBP would help.
Dr. Hassan is an excellent choice of procedure and techniques. My question is, did you try the non-atherectomy measures? Because visually there is no trem-like appearance of calcification, and you are having IVUS there. So did you think it was a severe calcification, whether in terms of depth or length, it was more than 5 millimeter or 0.5, or it was a high arc, I mean more than 270, therefore you opted the atherectomy device.
So since,
left main particularly.
Yeah, since the 2.5 balloon would not cross the left main distal lesion, so
cutting balloon after 1.5 balloon delegation.
So the crossing profile for a cutting balloon, I would say, would probably not cross that lesion if a 2.5 non-compliant, 2.5 compliant balloon is not crossing the lesion. So the
Dr. Hassan, excellent case. There was a question if you had IVUS on your table, why didn't done IVUS before stenting? It was a complex bifurcation. Could you have planned two-stent strategy?
Point taken, sir. When IVUS was on the table, before, after region preparation, ideally an IVUS should have been done.
I think overall, excellent result, well done, high-risk case. Yes, few caveats. Number one, was the patient aware the long-term results will not be as good as cabbage?
Yes, sir. He was.
Okay, so what happened? See how you sometimes describe to the patient. So, जी आपका यहाँ से हाथ पूरा सीना यहाँ से खोल देंगे, यहाँ से खोलेंगे, ये डालेंगे, ये infection हो जाएगा. But I think we need to be careful. Some cases definitely. So obviously, to be honest, balloon pump, yes, because you guys don't have impeller, you put it, but I don't think balloon pump was useful at all. Even good ejection fraction, I'm not sure impeller will be useful either. If EF like 35%, 30%, yes. And I think the rotablator to start with, for the left main, which is the only vessel to the heart, the importance is, or I would say the success is in quickness. And that if you want to do an IVUS here, put something there, and I think it's possibly more than possible. Quickness is important. I think I would have done the same thing. Quickly wire, rota, get the flow out to the left main, and the LAD, then you have a chance. So the IVUS, you assess it. I think once you've done a rota, then you revise it. I put a revise circle. Did you go straight away through with the single stent strategy, or you were thinking we will do it as it comes? Thinking to do it as it comes. Because you sent it every left hand. Plan was to stent it from the plan was to start with single stent. Yes. I possibly, yes, the single stent strategy is possibly the best strategy compared to. In that sort of scenario, rota, balloon, get the flow, give it time, patient stable, do the IVUS, then you think, okay, am I going to do the two-stent strategy or single? If you're going to go two-stent strategy, either you want to do tap or whatever you want to do, and it wasn't too bad for surgery, right? Because that was important here, right? Is that correct? So, yes, you need to be quick, get the flow from the left main forward. But once you establish a flow, you got some 2.5 whatever after you get done, then you have time. Now you think, okay, am I going to go single stent or double stent strategy? What do you do? Now you will wire. I would have replaced the rota wire with the microcatheter, with the balloon inflation. Then fair enough, you do the IVUS, then you think about it, and then you think, okay, looks like looks small. I don't know if it can dilate, it's bigger because the right is included. You blew the circ, you do the kissing. I didn't see any kissing. You didn't send the circ, you just put the struts in the. You did the port on it, right? But why you didn't think of the? No. The flow was good enough and flow was good in the LAD. Right? And the circ flow was also, there's something after the LAD. So you assess the circ. By the road of the. No, why? So that's what I'm trying to say. I mean, I think overall you did very well. Honestly, you did very well. That's up to you. Well done. You did but could have done me better, could have been different. That's what I think. Is that okay?
Hasan, it was a nice case. I have just a question. While you were doing the rota, did you put the wire in the circumflex or not at that time? Okay, so if you wanna put a wire in the circumflex, then how would you approach? If you want to put a wire in the circumflex, suppose the ostium is compromised and you are doing rota, to the left main to LED. So how will you approach then? My question is this: if you have two wires, like one wire is in the circuit, and you want to do rota of the left main to LED.
You want to say you want to keep the wire and do the
Yes, sir.
you want to bring it out.
Yes, sir. I want to keep the wire there in the circuit and do rotation from left main to LED. So suppose, sir, the circuit is compromised already. The circumflex has severe ostial stenosis.
You put wire in LED.
Yeah.
Now you're trying to wire a circuit, which is small vessel, spending time. Guide catheter is already in left main. Oh, you're already compromised. Even a wire will compromise the flow.
So you can't do rota while another wire is there in the circumflex.
I'm not sure I would, because left main, opening of that left main quickly is most important. Okay, so rotor wire and LED, you rotate the LED. Now you can breathe. Your sphincters are better. You don't have to go back to because you got a flow in the vessel. You're confident now. Right head is not blocking. Your wire is not blocking. Now you have time to assess. And because the wiring of circuit will take long without dilatation. And why would you like to wasting time? Because here, this critical thing is that critical left main stenosis to get the flow they could. If this patient had a once PT, that will be a problem.
Next. First national piece of local class PCI from
So we had an issue of old lady was diabetic hypertensive family stroke received by disease. Last two. This was a presentation is given. This was our diagnostic angiogram done through right radial. You can see on the angiogram the calcified vessel. It was a right dominant system. This is the problem. After the angiogram, our creatinine went up from normal to 4 days. Routine discussion was done, and surgeon at the time going for high risk. So now we were left either with medical therapy or local intervention with renal contrast. So there are since 2005, since the work was taken on by and in zero contrast and low contrast PCI. So they've been doing a lot of work, and now recently some Japanese studies have also come up with about 1,800 patients, and they have done almost 1 year to 2 year follow-ups, and they have come up with good results. So this is practiced all over the world. And there's another term called MCAD, MACD, maximum allowable contrast dose. So this is a landmark in our paper by in 2010 by Dr. Brown. We recruited almost 10,000 patients and showed that there is a ratio, there is a number for every patient the calculation of volume of contrast that you can give during a procedure. And that is dividing the patient's volume of contrast and divided by the EGFR. So if the ratio is 1, you are allowed to do that contrast. Otherwise, even if normal GFR, the patients would have increased risk of acute kidney. So the first step is to skeletonize the main vessels. You can see the left main and the LED and L6. And for this, you use world-class floppy wires, and you give hyper-equipments the wires to make loops, so to avoid distal perforations. Then we did iris to the left main. This is the iris. You can see in some places there are almost 360 degrees of calcium, and others it's 170 degrees. So initially our plan was not to use rotablation because it was a high risk patient and it could make the procedure even worse. But we had to, because NC balloon initially was not crossing and it had a warning effect. So we did rotablation, and after rotablation, I wish to show you that run as well, but you can see cracks already visible in the calcium. Then two stents were placed from the mid to proximality and left mid, and this was the final result. Post a single shot was taken to look for perforations and sections. Post PCI, I was also done, but the shortage of time could not be included in this presentation. But we can see a single shot of that post. So we have few take-home messages from this, that ultra-low contrast PCI is possible and safe for patients, especially for those who get referred for their creatinines and CKDs. And iris and rotablation should be used, especially for the left-brain PCIs who get or fellows activities. FFR is also used to provide this one the single form to short contrast to confirm the physiological significance after this time. Contrast can be avoided if you use echo after the procedure. So even the zero contrast PCI can be performed, but we found it with a single shot almost 5 to 6 hours.
Yeah, Ishaq, great case.
Dr. Ishaq,
I
excellent
want to
presentation.
ask one question.
My point in this case is, as this lady is 80 years old and she is CKD, there are 2-3 risk factors which are making him a high risk for bleeding. So what should be your post-PCI antiplatelet therapy plan in this very patient?
So that was the country was in the range of 23. So it was not actually the end stage disease, and she had never been dialyzed. So
I mean, what is the idea about giving a DAP for 1 month, as many studies have, and then use single antiplatelet therapy and preferably ticagrelor or P2 inhibitor for next 6 months, and then after 6 months only stick to one antiplatelet therapy, that will be aspirin only, according to latest guideline.
yes, sir. But usually you have good experience with Lavix. So information on aspirin. Yeah.
Okay, because the guidelines have clearly shown the superiority of this drug.
Yes.
Especially in complex PCI, where you are working on
Yes, sir, you're right.
we should change the strategy. And moreover, in our set of population, there are at least more than 20%, I think, the figure of non-responders to procedural. So, a person who has had a complex procedure done and he lands up into the again with the suppose the tube or subject tube, so that will be that can be a disaster.
So we collected first few cases.
And we have patients who comes from Afghanistan. So Afghanistan people, we don't put them on ticagrelor. The reason is because they can't find ticagrelor there, and then they are given non-standard sometimes medications. But you're very right that left main stem potent ticagrelor should be used. Exactly, there is no question about that.
Yeah, how you decided distal stent positioning without giving dye? Do you have sync via and IVUS you have? So
but we did that when you give it side by side, we measured the IVUS
So our plan was not to move the table, not to move the patient after what we had done actually. So when we had done the IVUS, we were not changing the position of the anything, to be honest, for the distal stent. So we thought that if, to the best of our knowledge, if he stays there and the patient doesn't move, the images don't move, no, so we will point it at the exact that same level probably. So yes, some bone calcium and things.
Maybe anaesthetic, look at it like whether the patient hydrated before properly or not. To me, I think possibly you got too scared. I understand. Okay, ideally should have waited 7 days. Okay, I think the 12 is wrong. I should have probably. I've done about 6 cases like this. I use a 7 French rider. I will take a microcatheter and park in the proximal part of the vessel. Okay, and part microcatheter there, because microcatheter you inject like 1 mil of contrast and 1 mil of serum. That's it. Okay, and in the vessel, and you see the vessel very well. Okay, and it's cheaper. Okay, I think our work is more complicated in the UK. Yes, you are a son. So
that's a bit of an exaggeration, Dr. Najib, isn't it?
So I have to use the 7 contrast. And then I'll just mark a guide, microcatheter is proximal LED, and then I'll do the calculations for calculation. Okay? And PCI would take off 6, 7 minutes. And I've done about 5 or 6 cases with really good results. But overall, I understand Bilal likes it. I know Ziad Ali, this is his IVUS and OCT, he's big used to, he loves it. I think that my first impression is he got too much scared about being out of the class. Yes, he did well too. But I didn't, one thing I didn't understand, you said you couldn't cross the lesion, but the balloon down.
Sorry,
That I didn't understand. Balloon for doubtful, you have to cross it.
It's your pressure, Dr. Najib, on him, so that's why he slipped over there. So.
Oh, good value. Fair enough. And then
yes.
So you don't know why. So you already use microcatheter.
Yeah.
It costs. Do you know that it costs 1 lakh rupees? Microcatheter. Oh, microcatheter. So we have got a Sehat card package. So we are different. We are KP. We are Sehat card package. So we don't shy away from money.
Dr. Ishaq, Dr. Ishaq, sir, it was a very nice case. I have 2 questions. What was the guide catheter size? 7 French. Okay, and why did you choose femoral access?
It is the same. We use them because
So you can use the 7 French via radial or not, especially in CKD cases. So the teaching is that if a patient has CKD and you are going for PCI, always try to avoid the use the spare the arms for for future fistula if they want to have a fistula. So another thing is that your last injection was pure dye that was not diluted, and the injection you show the dye was spilling into the aorta. So if you are using a low spolar or zero contrast and you are pushing so much dye, you can just review the last slide. So it was not a zero contrast case. So so that was not ultra low. If you see the last picture, that the whole dye was spilling into the aorta.
The primary preservation was there of custody so when we were against taking even this last shot, and we decided to do that, but Dr. Ali was insisting that people would always object to as that's why we just so you know that's why I told you to did five. He was going to FFR as well. Let me 100,000. So we have got package for IVAS, FFR, and okay. So what is the proposal? Whatever is left, you make a package take home. We'll go to the next case. Transcatheter approach, rotational understanding, and we have a same as Dr. Sanam is predicted, but the partner in that goes we have done this case. I presented 17 years old lady, presented with a shortness of breath, and while she asked 3 and 4, with 2 weeks or something. She is not getting uncontrolled. She's having a severe formation of aorta. Here, stenosis, which we have done the transverse cardiography for Snarkania and about 0.3% mortality by Euro score, and fragility score is about 2/4. So this is echocardiography. You can appreciate there the severe aortic stenosis, which is bicuspid in nature, and there is a high genetic transportation. So we have done CT scan on the base of our TAVI protocol because we have planned and TAVI we also participation. In this, you can appreciate here the angular size of about 20.7, and there is a moderate calcification across the annulus without areotic calcification. So this lady went the aorta because all the liquids stand when you inflate for 5, that stand with foreshortening. Okay, stand with foreshortening, and then your actual ostial will have made it longer. But there are learning points again. One, yes, I'll be very careful with any. And you use EBU. Yeah. Why you XP? You need a catheter who doesn't go in. Okay, you need to like check it. Okay, you really stay down. All right? And then, yes, you can well assess the iris and sizes. I still think the offspring of the that was bigger, and I think you start bigger to me was smaller, and I feel that we missed the treatment of the offspring. Is that okay? So, and again, in that scenario, you know, you take your time, the patient stable. Yeah. Take your time, patient stable. Okay, and then the ostium, it's a quite tricky thing to do. Placing and did you position the stent in the osteal left on you?
we definitely recommend. Which we think was the most, we took the definitely body and also which helps us, I think, gives us a and sometimes shows us things which we are missing in the body. In fact, some people also do. They will, if suppose you don't want to go after a short, they will take another long component in the fight. After the set, okay, back. So I'll go in higher. So where the colonics is finished, there is structure in the end. There the little bit of exercise. And it will go bigger. So ostial of the stent will go bigger. Okay, so that's what people tend to do. It's a little bit, and I will say that your guide we don't use worldwide. I'm not sure how much worldwide tax. Actually, the top of worldwide is not related. More, not like more protection of diving in. Okay.
Okay. Dr. Noor.
Excellent case. I,
Dr. Noor, in this case, just last.
चलिए फिर बाद में जो भी चेयरपर्सन बैठे हो ना हो गया टाइम हो गया ना No, basically the choice of guider here in this case matters a lot.
Leaving a wire in the aorta.
The only purpose of leaving wire is not.
No, it is very clear that when you are leaving the wire in the aorta, your catheter is not
that's
engaged to the ostial. The main purpose is when you are doing an ostial left main, that it should not engage. Number one. Number two, this is the reason you have put the wire over there. And when you have put the wire over there, you can take advantage of putting the stent wherever you want it to be. So that will definitely help you.
but you use as a marker and use as a.
It becomes a marker for you.
तारिक साहब खुद चले गए भैया हमें
भाई सेशन खत्म हो गया
डॉक्टर तारिक
सेशन
सर हमें भी हमें उठाए ना क्या बात है
एक पॉइंट है सर कि इसमें longitudinal cell deformation भी है the ostium was covered but by the IVUS or by balloon the stent become crumpled.
Yes, you're right.
In first scene you can
See that the ostium of the body was covered, but after ballooning and RNC, the stent become deformed. So it was uncovered.
Junaid Zafar, we can ask. Dr. Ali Reza to come on. Tariq Ashraf, sir. Professor Javed Sial, sir. So what we have a case presentation of the fellow for 5 minutes. There will be a discussion with audience interaction for 5 minutes and a case treatment and key learning for 5 minutes. So I will invite the first speaker, which the title is elevation after PCI to LAD, Muhammad Waseem. If he's around, come for the presentation.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Muhammad Waseem, postgraduate resident at Jinnah Hospital, Lahore. Today, my topic is ST elevation after PCI to LAD. So my topic is ST elevation after PCI to LAD. A newly diagnosed diabetic patient present in medical emergency with complaint of chest pain. His echocardiogram showed moderate LV systolic dysfunction. His ejection fraction was 40%. This is his ECG showing loss of showing poor progression of R wave in precardial leads. So we decided to do the angiography of the patient, and patient was brought to cath lab. These are the angiographic pictures showing moderate proximal and tight mid stenosis in LAD artery with dominant left circumflex showing no obvious lesion, and a small caliber non-dominant RCA. After angiography, decision of PCI to LAD was made. After pre-dilating the LAD with 2-0 semi-compliant balloon, we took a Promise Premier stent of size 3 into 24 mm and implanted it in LAD. Stent was inflated at the nominal pressure, and then the post-dilatation of the stent was done with 3.25 into 15 mm MC balloon. So these are the final results showing no residual stenosis, and patient was asymptomatic, widely stable. So we shift the patient. To CCU ward. After 7 hours of the procedure, patient again developed chest pain. This was his ECG showing dynamic ST elevation in the precardial leads. So we decided to do the angiogram here, and patient was shifted to cath lab at the night time. His angiogram was repeated, and there was total occlusion of LAD stent. LAD artery wiring was done with BMW wire, and there was a heavy clot burden. Here, we further post-dilate the stent with 3 into 15 mm NC balloon, intracoronary nitrates and tirofiban loading doses was given. ACT was checked and kept near 300 seconds. Here we decided to go for IVUS imaging. This is IVUS catheter passed through femoral root, and this is the IVUS picture showing a visible flap in the LAD artery. So this is a flap. I took a still image showing a visible dissection flap, this one. So we took another promiscuous stent of size 2.75 into 24 mm and placed it to cover the edge dissection by overlapping it with the previously placed stent. This stent was inflated at 12 atmospheric pressure. And post-dilatation of this stent was done with 3 into 12 mm NC balloon. So repeated session of IVUS was given, and this time there was a notable gap between the two stent layers. So we further post-dilate the stent with 3.5 into 9 mm NC balloon, and this is the final results showing a reasonable LAD artery flow. Patient was comfortable and asymptomatic, and a final run of IVUS was given, and there was no dissection flap, and the gap between the two stent layers was also not there. Thank you so much. So these are the key learning points in my short case. Coronary imaging studies are very helpful in decision making, as was demonstrated in this case. Acute stent thrombosis is catastrophic complication, and mechanical problems are leading cause of it. Stent edge dissection should be ruled out by taking opposite projection during PCI. And last, repeat intervention at night time was really life-saving in this case. Thank you so much.
So any comments from the chairpersons, from the panel of experts?
I think the edge was
wonderful teaching case. Actually, I was missing the orthogonal views for the proximal LAD after stenting. I couldn't see any orthogonal view in the caudal views, neither present or caudal, or to look at the proximal, look at the result for the proximal LAD after stenting, since I could appreciate some haziness over there. Although it turned out to be something different, there was an edge dissection at the distal end, but still, was there any consideration to cover that area as well? Was it not better that you could have brought the stent right at the ostial mortality and not leaving the disease in the proximal LAD? Still, there was some residual disease.
Yes, excellent question. I am Dr. Ahmed Mukeet, and I was one of doing this case. In the image in which there was a total occlusion of the stent, there was a spasm before the inlet of the stent, and at that moment of stent occlusion, in that image, it looked a more prominent lesion, and it settled after giving intracoronary nitrates injection. And in last caudal view, which he didn't show in this slide, it was but just a mild lesion, as was in first angiographic image.
In the caudal view, it is head-on, end-on. So probably you may not see the thing, but this edge dissection was probably, I think two of us, we just saw that this was edge dissection to start with. rather than doing the IVAS later, if you were in doubt, probably IVAS should have been done at
Yes,
that
this
very
is the
moment.
this is
I think there was no need for IVAS either. This was a dissection, edge dissection at that very moment, and should have been stented right there and then.
yes, I agree. And in retrospect, I consider this that just to highlight the importance of intravascular imaging, that the dissections or any mechanical complications are best picked on IVAS imaging, and it has to be a routine in our practice. Regarding the last image after the first PCI, there was no haziness or no dye staining. There was edge dissection, which would be grade 1, and the patient was fine. There was no ECG changes or hemodynamic instability.
Thank you, Dr. Ahmed. And we would encourage if the presenter himself responds to the questions, because he will be evaluated on this base as well.
Okay, I have a comment regarding this case, because this we know this is a complication of case, and sometimes we encounter, and it was excellently taken. But the first procedure, when you completing the first procedure, we all know that there are certain risk factors for stent thrombosis. Few are from procedure related and few are clinical related. But as far as we completed this procedure, as Dr. Saab has already pointed out, that we're not clear what ostial LAD at that time, was it healthy or not, and there is also dissection, probably distal age. So these are procedure related features which are related to stent thrombosis. So that can be anticipated easily before completing first procedure. That's my comment.
Just one quick question to ask. You took the patient cath lab 7 hours later. Okay? When actually patient develops symptoms after the PCR, it sounds to me 7 hours is too long. Did somebody waited, oh, let's see, this को nitrate infusion लगा दें, इसको morphine दे देते हैं, उसको कुछ चीज़ दे दें. You know, when you saw the PCB changes आ गई हैं, अब तो कुछ नहीं हो सकता, अब लेके जाना होगा. You know, when actually pain started. That doesn't answer.
Sir, pain exactly started after 7 hours. Patient was in the ward and doctor was looking in.
That's right. Do you do any post-procedure ECG?
Yes, sir. And there was dynamic ST elevation in the precardial leaf.
No, immediate post-procedure ECG.
Sir, we do the
and what was it?
ECG. ST was settled.
No problem. Fine. Because I think you did well to take it, but sometimes the problem is patients have taken, even we think, oh, 7 hours good, middle of the night, but already that may be 6 hours late. Still, okay, you still lost a lot of myocardium. So need to be careful. If the patient has symptoms after the procedure, should have low threshold.
Thank you.
So the take home is that at least
The volcano IVAS you guys used, was it a volcano IVAS? 15 megahertz, isn't it? That's why the pictures are, you guys should use the other one. Hello.
So I will ask for the next. So the take-home messages are two, that whenever you put a stent in, always make sure in two projection, the proximal and the distal part. And whenever the patient goes back, so he should be monitored, and if there is any symptom, he should be quickly addressed to prevent the myocardial damage. So we will move onward with our next speaker, and in dire straits, left main occlusion and LIMA dissection by Hasan Sohail. If he is around, he can come to the dais.
Even if you don't have acute event in these cases, if there is some micro dissection, you can later on have candidaper stenosis in these cases.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Hasan Sohail from the Tabba Heart Institute. And The case I'll be presenting is of a 58-year-old gentleman who is diabetic and hypertensive, who had coronary artery bypass grafting in 2006 with LIMA to the LAD and SVG to the OM grafts. He had PCI to his native RC in 2016 and then in 2017 for ISR. He underwent a left heart cath and graft study at another facility for worsening, for a high-risk DSC, which was done for worsening angina. And it was reported that his left main stem was totally occluded. He had patent LIMA and SVG grafts, and his native RCA also had patent stents. Thus, he was discharged from there, and after medications were optimized, he presented to our facility the next day with typical chest pain, and his cardiac troponins came out positive. He was managed, the ACS protocol was given, and his symptoms settled with IV GTN and beta blockers, and he was admitted to the ward. A few hours after admission, he developed a polymorphic VT, and he was immediately cardioverted. His CD was reviewed again, and there was haziness noted at the ostium of the LIMA on disengagement. So the patient was taken to the cath lab immediately. The left main, it was confirmed that the left main was occluded distally. The SVG graft to the OM was patent. The LIMA non-selective shot. Could you kindly click on the last slide, the one on the right hand? Play that video, please. The last one. A non-selective shot was taken, and there was total cessation of flow in the LIMA, and an ostial dissection was noted. The video, I'm afraid, is not going on. So a JR4 guide was taken, and the LIMA was wired with a BMW wire. The true lumen was confirmed using a fine cross microcatheter and a small distal dye injection. A 202-25 compliant balloon at 4 ATMs was inflated at the ostium, which resulted in this resulted in flow, but showing that the dissection was extended up to the middle of the LIMA. It was thus stented with a 275/30 DES. And then a 3540 DES was placed from the ostium of the LIMA to the proximal LIMA. After placing the stent, at the stent edge, there was a suspicion whether it was a dissection or whether there was an accordion effect, which is very common in LIMA. So the wire was retracted up into the proximal stent, and at the end, the distal edge dissection was noted after the wire was pulled into the proximal stent. It was covered with another 12 DES at 12 ATMs, and after post-dilation, this was the final result. The patient had an unremarkable hospital course post-PCI and was discharged a day after. He is in the regular follow-up and doing well. It is a very rare case, basically, LIMA dissection. This is a case report published, which has almost a similar presentation to our case, in which an intervention was done on the RCF, and the patient had a LIMA dissection and presented 2 days later. The patient again had some symptoms and underwent an angiogram. 2 years later, the LIMA intervention was doing fine. This is another case report, as well as a review of literature published in 2015, and after that, according to this paper, only 7 reported cases were present of LIMA dissection, and 3 of which were iatrogenic, and patients were doing well in follow-up. Thank you.
Thank you for an excellent presentation. So now we can have a panelist. Yeah.
Confusion, sorry, unless everybody is clear. So you did the first angiogram, and at that time, the LIMA
It was done at an outside facility.
Since the angiogram? Since the angiogram, the patient having chest pain. Okay. And the picture you showed, that was the pictures from there?
No, these are the pictures when we took the patient to the cath lab after he developed ventricular tach.
And how long the angiogram was done? And
Let him respond to the question.
actually, हमारे पास angiogram नहीं है.
नहीं, let him respond to the question because we are.
We'll mark you 0. So we polymorphic VT. You think it was due to this dissection?
Yes, likely polymorphic VT was due to this dissection and the cessation of flow in the LIMA. His troponin was positive. Our baseline at the hospital is around 34. His was around in the hundreds.
Just make sure you haven't missed the plan with me until we
No.
Fair enough. We actually nowadays mostly do CT angio in grafts. Very, very rarely we do the invasive angio in post-CABG patients. Mostly we do. And again, sorry, why did you go femoral? Not left radial?
Not left radial. We do some of our cases at a center from the left radial, but we're more used to, you can say, doing the femoral.
I know people are more used to radial now.
The right
So
radial.
why did you do left radial? I'm just asking.
For quickness of the procedure.
Okay.
Yeah.
I personally do all my post-CABG cases. If they have a LIMA plus SVDs, I tend to do them femoral.
Why?
It's easier. It's very frank.
No,
It's easier.
what is the best, what is in the most patient interest? That counts.
I know, I've done it. I've done it left radial, I've done it left radial, right radial. I'm not doing that. अच्छा, इसमें actually एक दो points है. When you are wiring this, the wire is very smoothly in BMW. But how do you make sure that you are in the lumen or the pulse?
Go to the LED. Go to the LED.
No, that was occluded. That is occluded. Just use a microcatheter, any microcatheter.
And microcatheter, okay. Do you inject through the microcatheter?
Of course.
Why?
Half saline.
But if you are in the false lumen and you are injecting there,
So you inject very small, tiny amount of dye without a pressure.
I think what I did was I connected the microcatheter to the transducer. So if you are having an arterial pulsation, that is very short. I've done it multiple times.
I'm not sure.
Yeah.
So
Any other
I've got one other that because if usually just probably a hint, it was a very good case. So what I do usually when I rule out any wire biasness or wire artifact to it, I just pull it up to the radio opaque segment. I don't pull it all the way back because you're lucky if you've got a dissection and you pull it all the way back, you might never be able to cross it. So always break, because the main purpose of it is to bring to the softer portion of the radio opaque segment. So
We use a microcatheter as well. Put on the microcatheter. I was reading the literature.
no, the reason behind that is when you pulled it back just to see whether it was a spasm or anything else. At that point, the whole purpose of this wire is that because this radio opaque segment is softer, the rest of it is a bit harder. So always leave the radio opaque segment below the point of dissection, so you can wire it easily down. So.
It's not really for spasm, it's for ruckling. You know, like a shalwar, when you put a nala, so you're ruckling, because the LIMA has got lots of tortuous, he's taking up. He's right. Go to our back, radio big part is very soft. It will take the vessel shape. And if there is no ruckling, it's gone, that's fine. And then you still in the vessel.
There is one more thing, small. Once there is a wire bias or disrupting bias, again, I would second Vasa that you don't have to take the wire all the way out. Since if you are there is a dissection, you may end up in a problem. So one point is that you introduce interfering nitrates, good amount of interfering nitrates, and see the result if the spasm goes out, or does it change the morphology? This struggling area, does it change the morphology? And secondly, careful runs. Distal to the area of interest, I mean, distal to that side of stenosis, 2 or 3, 2 and 4 runs of that guide wire, it may again change the morphology of that lesion, so that you
audience? Yes, please.
Don't give injection through the microcatheter whenever you are doing any CTO lesion or other lesions. The other thing is, if you are not sure about you are in the lumen, you can do the IVUS and you can see that you are in the lumen or not. But I have asked many operators about the
So my take on this, because I do CTO, my register they're sitting behind, they always say, sir, injection करके check कर लें. I never do it because that's the end of your case sometimes in a CTO. So that's one thing. The second thing is this, that we have got Sehat card, so IVUS covers that. So we put IVUS in. Okay.
CTO is the different. With CTO, you will not even put a microcatheter, would you? In a CTO, if you are not sure you're wired in the main lumen, would you put a microcatheter?
No.
So there's no question of injecting CTO integrally. I'm not sure, these are not the same thing we're talking about. Okay, and CTO, mostly you do retrograde, you go second injection, and that's what you use it. CTO, I will not even put a microcatheter.
So I'm sitting next to Dr. Najib. I put a microcatheter through CTO. The reason behind that is, in CTO, you always go somewhere subintimal. Then you come into the true lumen, isn't it? There are, like, when we were doing like this other case, stingray balloon, you're always subintimal. You go into the true lumen and things. So it's only the injection which causes the hydrostatic pressure, which causes the expansion of that lumen, that causes you never to enter into the true space. So I again would say that probably yes, I have given distal injections, but at very, very rarely, just to show off that I'm in the distal end of it. But I would say, in my opinion, don't do that.
I thought about using IVUS again, but the problem is I have never done IVUS in a LIMA. Yeah, one thing. And then second, whether you are in the true lumen or the false lumen, the atheroma around the catheter tells you that you're in the true lumen. But in LIMA, there is no atherosclerosis actually. That's why I use it for it. So I don't know whether it will help or not.
Okay. Actually, injection should not be given same if you pass another wire and you are quite sure that I have crossed into the actual true lumen and far away from this dissection area. Then there the injection should be given, not at the dissection site. It should be, if there is the same dissection wire should be kept at the same place.
The injection was not given at the dissection site, it was given very distally.
Yes, it should be distally. By landmarks, you confirm that you have gone far. So if suppose the dissection is in RCA proximal and you have gone to the PDA, PLB, and you know that this is the PLB, so there you can give injection.
Thank you so much.
And that also slow.
I would request that we should be limiting ourselves to the time. So I will ask the next speaker to come is Dual Catheter by Khalil Ahmed. Dual disaster. Dual disaster.
Assalamu alaikum, I am Dr. Khalil. I am here to present a case with title of dual disaster in coronary intervention. So my patient, 37 years, gentleman, having no comorbid, presented with acute coronary syndrome 1 year back, and he was taken to the cath lab for the coronary angiogram. You can appreciate that right coronary artery looks non-obstructive, and there is severe disease in ostial left main extending to the LAD. So he was presented with acute coronary syndrome, so we planned to stent the left main to LAD. You can appreciate here the left main is severe disease extending to the LAD. So the 3534 stent was placed and post-dilated with 4O balloon. You can appreciate here the end result. Anyway, after 1 year of this angioplasty. He came in OPD multiple times with typical symptoms, and his medical treatment was optimized, but he was still symptomatic despite of medical therapy. So we plan to do the coronary angiogram again after 1 year. You can see here, you can appreciate that there is severe disease in ostium of circumflex. So we decided to stent this ostial circumflex. You know, 1 year back, there is a stent is implanted from ostial left main to LAD. You must keep in mind. Then we took a guider, EBU 35 guider was taken, and we took 2010 balloon, and we tried to pre-balloon this ostial circumflex. After that, we plan to cross the stent up to the ostial circumflex, but unfortunately the stent was not crossing from the left main. Then we took the guide extension for the support, but unfortunately still it was not crossing. Then we decided to change the guider from EBU to the AL guider. Still from AL guider, it was not crossing. After that, we planned to take the EBU 40 guider for the maximum support. So at this point, we removed the whole system like guider, coronary wire, and even stent. When we removed the whole system, and when we checked the stent, there was only balloon, no stent was mounted over there. After that, we were searching the stent over the table, and then we did the fluoro from head to toe. Fortunately, we found that it has been dislodged in the groin. You can look at here. After that, we took the EBU 40 guide, and we tried to implant another stent in the ostial circumflex. You can see here, but it was not crossing. And unfortunately, our second stent, again, it was dislodged. But this time, it is dislodged. It is dislodged within the old left main stent, you know. So what should be done here? At this time, we remove the circumflex wire and we put it in LAD, and then we entangle 2 wires in the LAD, and then we pull out the whole system. So fortunately, we retrieved our dislodged stent, which was in left main. But you can look at here. Okay, this is the dislodged stent in the left main. So after that, we planned to defer the procedure, but we took the diagnostic shot with JL catheter. You see here what you are appreciating here. Can you play it, please? Can you play, please? Anyway, once we retrieved the stent within the left main, unfortunately, we extracted whole stent which was implanted 1 year back. You know? So, you know, the 1 year back stent came out extracted with whole intima. So at this time, patient becomes sick, he developed chest pain, and at that time, we also become frustrated, and we again took the guide, and here you can see here, we left the circumflex as it, and we took the stent and implant from the left main to LAD. And alhamdulillah, patient improved, and it was post-dilated. Look at this.
Excellent.
Thank you.
So, excellent case. And a great serve.
Yes, please.
So, excellent, Seth. We are now waiting comments from the experts.
First thing is, I would say this is the best case to share, and we can learn people from it, and hats off to you that you did have the courage to share honestly.
Any comments from? Yeah, please. Yes.
Arsalan said, don't respond. He must respond, but basically I am involved in this case. I was doing this case. I'm happy that all people are laughing, but you can imagine what could be the position of this was a young man who was a routine worker. He has repeated chest pain. He has visited different hospital for last 1 year. Initially, this patient was dealt as an ACS, and you all are agree that patient only left main was stented at that time. But then he repeatedly went to a different hospital of the city. Everybody says that treatment maximize kar lo. Then I told him that we are going to provisionally I want to do bifurcation like a tap. That's the only option available. So this whole thing happened in the cath lab. Ultimately, when we take out everything, I thought then just stop a procedure here. I asked one of my junior consultant to take a shot with jail that we should stop. Then he said, "Don't go, sir. Don't go out, sir." You can see. Then we see that whole stent which we put 1 year back was on the table, and patient started chest pain at that time. तो इस पे मुझे वो याद आया कि खाया पिया कुछ नहीं, गिलास थोड़ा भरा ना, एक स्टैंड लगा हुआ था उसकी जगह 2 स्टैंड लगा दिए, और ऑस्टियल सर्क वैसी ही रह गई जैसी पहले थी. तो लेट्स होप फॉर द बेस्ट. नाउ पेशेंट इज डूइंग वेल. प्रोबेबली अगर वो दोबारा आएगा तो देन वी विल ट्राई अगेन.
Perfect. Can I ask?
Is the patient still alive?
Last one, not about guide characters. How many times you have to change your own trousers because they were wet?
I've got a question here now, sir.
In groin, that's very pertinent question. If you go and see the literature, when we are very dislodged stent until it cross the arch of aorta, that's the only thing. But that can be attempted from contralateral side. But usually we have few cases where we left these stents in the leg, and literature say there is no problem in leaving these cases.
Can I ask you?
Yes, please.
Yes, sir.
Why do you think that your circumflex stent was not doing it? And what could you have done?
Actually, there was a little bit issue regarding the support, guide support, number one. Number second, there are multiple issues. One of them is guide support, and other, most probably the left main struts are not open properly, because at that time, most probably the port was not done properly.
I think it was clearly a 4 plus vessel.
Yeah.
So what he needed to do was to do a port with a 4.5 at least, make the struts open up to the surface, and then try it.
Right.
You will expose the intima by doing that. So you will make a bare metal stent in the left main.
Prevent this disaster from happening.
My question is slightly different.
In the iliocaudal view, the sun seems to be a little bit retroflexed, and probably they didn't do it that time. In other views, it's okay, but in the iliocaudal, it seems to be retroflexed. So that may be a cause of the stent not going there and dislodged.
To be honest, you can write a book about this now. So I'm not sure there's a point going through it, whatever. You can spend hours on it.
Okay. Thank you very much. Thank you.
Everyone will be worried when it happens. Because we've still got some time. Just one quick question is that once you've got everything out, now why not to treat the left circumflex and LED in a normal way?
That's the point, actually. At that time, actually, patient developed chest pain and he become hemodynamically unstable. If we try to, at that time, we try to do the bifurcation, it takes long time. And we don't know what will be the fate of patient. If let's suppose he becomes sick, he become collapse, then what will our answer regarding that? That's why we put the stent in from left main to LED to rescue the patient at this time.
It's fair comment. It's no objection about that. It's just in general because obviously everyone would do the safety of the patient first. But yes, if you think he was unwell, then obviously there's no question that to think of any bifurcation stenting. But just if he would have been well, probably have been. I would have probably still, once I would have secured the LED, I might have teed or the tap with the left circumflex. But then again, it's a retrospective observation. It's nothing to do with your current presentation.
Thank you.
Had this been an old man, he would have succumbed.
Any comments from the audience? Yeah.
Right from the angiogram you showed earlier, if you see the circumflex, it's ostial disease and very minimum area is diseased. Can I put in a comment and ask a question? If we have drug-coated balloon available in our inventory, can we go for DCB instead of putting a stent there? And was it in the plan? Thank you.
No, actually DCB was not in plan at that time, and we were thinking at that time straightforward to put the stent because it was the severe disease and involving the ostium.
You can debit because my worry would have been if I stent this into the, where would be landing that stent? Because the first LED stent will always be damaged. We were just able to achieve that I would debit actually, I would put a drug-coated balloon in it rather than anything else and then see.
Just a quick last.
My
Yes.
question is that to all the panelists and all the colleagues, that it takes a lot of force to take even the jail wire from the artery. Then how much force was required to take the old stent?
No, it was not required hard force, but we removed this whole system smoothly.
Is it possible to take a long standing stent out of the artery without any force? Definite.
Reason उसका ये था कि इसका जो dislodged stent था, it will in between straits. So definitely थोड़ा
That was understride stent basically. That was not endothelialized.
Thank you for an excellent presentation, a great serve and a great case. Now I will invite the next speaker, how to deal with heavily calcified left main bifurcation, Dr. Muhammad Walid from Peshawar Institute of Cardiology.
Hello.